Here's a USMLE-style question on angiotensin-converting enzyme, ACE. Question. A 58-year-old man with a history of hypertension and type 2 diabetes mellitus presents for follow-up. His blood pressure is 145 90 millimeter drags, and he is currently on lisinopril, an angiotensin-converting enzyme ACE inhibitor. His most recent laboratory results show serum potassium, 5.3 millipascal per liter, serum creatinine, 1.9 milligrams per deciliter, baseline 1.2 milligram, blood urea nitrogen in 22 milligram deciliter, urine protein creatinine ratio 1.2, normal 0.2. Which of the following mechanisms is most likely responsible for the increase in serum potassium in this patient? A. Inhibition of aldosterone secretion. B. Inhibition of angiotensin II production. C. Inhibition of renin release. D. Direct effects on the distal tubule. E. Increased sodium reabsorption in the proximal tubule. Answer: B. Inhibition of angiotensin II production. Explanation: ACE inhibitors, such as lisinopril, work by inhibiting the conversion of angiotensin I to angiotensin II in the lungs. Angiotensin II has several critical physiological effects, including vasoconstriction, increases blood pressure, stimulating aldosterone release from the adrenal glands, increases sodium and water retention, stimulating thirst. By inhibiting angiotensin II production, ACE inhibitors reduce aldosterone release, leading to decreased sodium and water retention. In addition, lowered aldosterone results in impaired potassium excretion in the kidneys, which can lead to hyperkalemia, elevated serum potassium levels. This is a well-known side effect of ACE inhibitors, particularly in patients with renal dysfunction or diabetes, where hyperkalemia can be more pronounced. Key points about ACE inhibitors. Mechanism of action: inhibit angiotensin-converting enzyme ACE, reducing the production of angiotensin II and subsequent aldosterone release. Common uses: treatment of hypertension, heart failure, chronic kidney disease, and diabetic nephropathy. Side effects: hyperkalemia due to decreased aldosterone release, acute kidney injury due to efferent arteriolar dilation, cough due to bradykinin accumulation, angioedema, rare but serious. Why other choices are incorrect? A. Inhibition of aldosterone secretion. ACE inhibitors indirectly inhibit aldosterone secretion by reducing angiotensin II levels, but this is a consequence of ACE inhibition, not the direct cause of hyperkalemia. Inhibition of renin release. ACE inhibitors increase renin release due to feedback inhibition of angiotensin II, not inhibit it. Direct effects on the distal tubules. ACE inhibitors do not have direct effects on the distal tubule. They affect aldosterone and angiotensin II levels, which then influence renal potassium handling. E. Increased sodium reabsorption in the proximal tubule. ACE inhibitors do not directly affect sodium reabsorption in the proximal tubule. Instead, they decrease sodium and water retention indirectly via their effects on aldosterone and angiotensin II. Clinical relevance: ACE inhibitors should be used cautiously in patients with renal impairment or diabetes, as these individuals are at higher risk for hyperkalemia and acute kidney injury. Patients on ACE inhibitors should have regular monitoring of serum potassium and renal function. Would you like to dive deeper into the mechanism of ACE inhibitors? Or perhaps a question on aldosterone antagonists?